Yeah, Arti.
Yeah. Good evening, everyone, and welcome to today's ISA National PG online class. These classes are held on every Monday at 6:30 p.m. Myself, Dr. Aarti, alumna of St. GS Medical College and KEM Hospital, Mumbai. Today's topic is Neuromuscular Physiology and Perioperative Neuromuscular Monitoring. Now, before we proceed, let us invoke the blessings of Goddess Saraswati. It is my immense pleasure to invite Honorary Secretary ISA National, Dr. Sukhminderjeet Singh Bajwa sir, to speak a few words. Good evening, sir.
Good evening, Arti. Thank you very much. Today is another important day. The class, I think, when we started the post-graduation, the neuromuscular monitoring, the chapter was very difficult for me at that time with all that type of crude methods, with all the most sophisticated being the train of four. Otherwise, the tetanic stimulation and all those crude methods were there. And we never had a comfort in learning those methods. But presently, the way we have advanced in the techniques, the monitoring gadgets, so many things have come up. Life have become easier. But still today, if you want to say that we are going to dependent upon the electronic gadgets to see the potentials or whatever, the muscular stimulation or their action potentials, I think it's not complete. Still, till date today, we have to combine the clinical acumen. That's very, very important. Even the electronic gadgets may be misleading sometime or may not be giving the complete information, although they may be quite accurate. So I think the clinical acumen of a physician, of a anesthesiologist over the years is very, very important. That's why we always read the books along with the online courses also. The books are the most important. So goes for the clinical acumen. So I think we will be dwelling light upon this topic in this class, and we have a very good team in Dr. Subir Mukherjee sir and his team, including Dr. Neha. So let us start with the class. So Aarti, you can proceed it from here to take the class further.
Thank you, Honorary Secretary, sir. Now I'd like to introduce my co-screen coordinator, Dr. Nimita. Over to you.
Thank you, Dr. Aarti. Good evening, everyone. I'm Dr. Nimita, Senior Resident, Department of Anesthesiology at Father Mullah Medical College, Mangalore. It is my immense pleasure to welcome our esteemed faculties for today's class. Our first faculty is Dr. Subir Mukherjee. Sir is Sir
Let
is
us share the screen. Let us share the screen, then you speak.
Not showing.
Aarti, you do one thing. You stop sharing and you share again.
Okay, sir.
Our first faculty is Dr. Subir Mukherjee. Sir is Professor and Head of the Department of Emergency Medicine and Professor in Anesthesiology at T.S. Mishra Medical College, Lucknow. Sir has a teaching experience of 15 years. Sir's areas of interest are critical care and regional anesthesia. Sir has got various publications in 12 national and 2 international journals. I welcome you, sir. Our second faculty is Dr. Neha Sharma, working as Associate Professor, Department of Anesthesiology and Critical Care, T.S. Mishra Medical College. Ma'am has a teaching experience of 10 years with areas of interest in obstetric and regional anesthesia. Ma'am has got various publications in more than 10 PubMed and 3 international journals. I welcome you, ma'am. I also welcome our respected class coordinators, Dr. Madhuri ma'am and Dr. Nishant Sahi sir, for today's class. Before we begin, I would like to remind all the audience a few rules that should be followed. All audience will be muted for the entire duration of the talk and are kindly requested to keep their videos off during the session. Queries can be put up in the chat box, which will be duly addressed by our faculty. Now I request our beloved faculty to introduce the postgraduates and take the session forward. Over to you, sir.
Thank you. Good evening, esteemed faculty and students. We welcome you to the PG online classes on behalf of self and my co-faculty, Dr. Neha Sharma. Our thanks to the ISA Governing Council and Honorary Secretary ISA, Dr. Bajwa, for giving us an opportunity to participate in these online classes. Today's topic will be covered in 2 parts. Dr. Sachin Mishra, who's the first speaker, he's the third-year resident in our college, in our department, and he'll be covering the topic of neuromuscular physiology. The second part of the lecture will be neuromuscular monitoring, which will be covered by Dr. Pawan, who's also a third-year resident. You all are aware that neuromuscular physiology and neuromuscular monitoring form part of our core knowledge. And without the knowledge of these two, it's almost impossible to clear your MD exams and for your everyday clinical practice. From the exam point of view, this is a very important topic. We keep on getting short notes, long questions. Without further ado, I hand over the session to Dr. Sachin to carry over the session. Thank you.
Thank you, sir. Thank you for a very brief intro about the topic. Now, as slides. So, first of all, a very big thank you to the ISA for giving us, the PG residents, a very nice podium for these online PG classes where we discuss very interesting topics. Thank you for the faculty moderators who have given us this opportunity to present here on this very big podium. So, my part of today's topic is neuromuscular junction and its physiology. So, introducing this topic, the neuromuscular junction is one of the most widely studied synapses. Electrical neurotransmission and the presence of chemical compounds with a critical function for the transmission of information from nerve to muscle was first described by Claude Bernard. Sir Bernard was able to study the neuromuscular junction with intracellular electrodes. Then Sir Henry Dale in around 1936 proved that acetylcholine is also a neurotransmitter in the neuromotor synapse. Then Eccles for the first time succeeded in inserting microelectrodes into the nerve cells and researching the basis of membrane potentials in the synapse. Now coming to the neuromuscular junction. The neuromuscular junction is a chemical synapse at which a nerve impulse triggers the excitation of skeletal muscle. Motor neuron in the neuromuscular junction corresponds to presynaptic cell, and in this electrical signal is converted into chemical signal, while as skeletal muscle fiber corresponds to postsynaptic cell, and here again chemical signal is converted into electrical signal. So this is a very basic structure of neuromuscular junction, showing an axonic terminal in the yellow containing mitochondrion and the synaptic vesicle. Then there is a white potential space, that is synaptic cleft, which is then followed by a pink colored postsynaptic membrane. This is the motor muscle. Now this is a colored electron micrographic presentation of axonic terminal of the motor neuron and the skeletal muscle fiber. The pink or the red structures are the skeletal muscle fibers, while as the brownish colored or dotted structures are the neuromuscular junction. Before that, there is the axonic terminal clearly shown. Now, physiology of neuromuscular transmission says that neuromuscular junction is a specialized on the nerve side and on the muscle side to transmit and receive chemical messages. Each motor neuron, that is alpha, runs without interruption from the ventral horn of the spinal cord to the neuromuscular junction as a large myelinated axon. As it approaches muscle, it branches to contact many muscle cells together in functional group known as motor unit. Now we have a new word, that is motor unit. So what is motor unit? So every system has a functional unit. So the nerve muscle functional unit of the neuromuscular junction is the motor unit. In muscles concerned with fine graded precise movement such as muscles of hand and eye, each motor unit innervates 3 to 6 muscle fibers, whereas large weight bearing muscles, for example thighs and hips, have large motor units that contain more than 6 muscle fibers. Now coming to the anatomy of neuromuscular junction, the components are broadly divided into 3 parts, that is presynaptic membrane, synaptic cleft and the postsynaptic membrane in the neuromuscular junction. So here this is a very beautiful diagrammatic picture showing the A, that is motor neuron from the ventral horn of the spinal cord, B, the axonic terminal, where in yellow we can see the presynaptic membrane, in the purple color we can see the synaptic cleft, whereas in the brown part we can see the muscle part. So when we further see into this, so motor nerve fiber brings there is an action potential, and change of this action potential causes some changes in the axonic terminal. So what are these changes? These are opening of voltage gated calcium channels, entry of calcium ions from the extracellular fluid, then opening of vesicles and release of acetylcholine. Now this acetylcholine releases into the synaptic cleft and passes on towards the postsynaptic membrane, where there are nicotinic acetylcholine receptors. So binding of acetylcholine with a receptor and forming acetylcholine receptor complex in the postsynaptic membrane tends to open the ligand gated sodium channels. This causes the entry of sodium ions from extracellular fluid, and this develops a depolarization or an end plate potentials in the postsynaptic membrane. Then what happens in the muscle fiber is generation of action potential causes excitation contraction coupling, and finally the muscle contraction. So this is all the process in a summarized way of the neuromuscular transmission. So this is also near about the same slide, a very beautiful picture showing the sun-like appearance where the action potential arrives and initiates the synaptic transmission in the yellow color, followed by there is a conformational change in the voltage gated channel where calcium enters the axon terminal or the presynaptic knob. Then this calcium entry tends to move these acetylcholine containing vesicles near the presynaptic membrane, causing fusion, docking, and finally exocytosis. Then after the process of exocytosis, there is acetylcholine released into the synaptic cleft. When this acetylcholine released into synaptic cleft, it is of 2 types. One, as it is at one of its types floats in the synaptic cleft, while the other attaches to the nicotinic acetylcholine receptors present on the postsynaptic membrane. Then the leftover, the acetylcholine hydrolyzes into acetyl and choline, acetate and choline, and this happens because of the enzyme present there, that is acetylcholinesterase. The choline component goes back to the presynaptic terminal for again usage and formation of acetylcholine. So with after this slide, it is what is presynaptic component of the neuromuscular junction. So as the axon of motor neuron approaches the muscle fiber, it loses its myelin sheath and divides extensively into several fine branches, that is axon terminal, and it is covered by Schwann cells. Each terminal is expanded at its end to form a knob-like structure. This is called as synaptic knob or terminal bouton. This terminal bouton lies in the group, that is lies in the groove that is synaptic trough in the surface of the muscle fiber. Now, vesicles are clustered around the specific points that are active zones that are present on the presynaptic membrane itself.
Okay. Good evening, everyone. Let's make this session a little more interesting. So in between, after every few slides, I'll be putting up an MCQ so that all the students are feeling interactive and they are involved in the presentation. So the first question is, why doesn't an action potential always follow every end plate potential? Four options are because end plate potentials are always sub-threshold, because of temporal summation requirements, because the end plate potential must exceed the threshold for the muscle membrane to fire an action potential, because acetylcholine acts slowly.
So Dr. Jyoti has answered the quickest, fastest fingers first, and almost all the audience has reached to the common conclusion, that is
Yes.
option C, because the end action potential must exceed the threshold for the muscle membrane to fire an action potential.
Yes. So very well done, Jyoti, because you attempted it the earliest.
So moving towards the next slide, that is acetylcholine synthesis, storage and release. So synthesis occurs in the presynaptic terminal from substrate choline and acetyl coenzyme A. So this in presence of choline aminotransferase and catecholamine O methyltransferase forms acetylcholine. This is released in synaptic cleft, and after its release, acetylcholine binds to the nicotinic acetylcholine receptors, while it is at the same time hydrolyzed by the leftover is hydrolyzed by the acetylcholine esterase enzyme into choline and acetic acid, and this choline by 50% of its number is transported by carrier facilitated transport again to the presynaptic terminal to again form acetylcholine. So what are synaptic vesicles? As we are all talking about in this seminar, that what are synaptic vesicles? It is in the presynaptic terminal, the round body structure shown in this picture that are brown in color are synaptic vesicles that contain acetylcholine, the neurotransmitter, the meters formed by the Golgi apparatus in the cell body of the motor neuron in the spinal cord. Now, these are transported by the exoplasm to the neuromuscular junction at the tips of the peripheral nerve fibers. There are about 3 lakh of these small vesicles collect in the nerve terminals of a single skeletal muscle end plate. Ma'am.
So the next question is, the action potential in muscle fiber is generated by the influx of potassium, sodium, calcium, and chloride. Okay, so I think Shraddha has answered the.
Shraddha has answered sodium.
Yes, the answer is sodium. So, very good, Shraddha.
Moving towards the next slide. So calcium here in this beautiful pictorial diagram, we can see that the calcium influx from the extracellular fluid into the presynaptic terminal leads to the exocytosis, fusion, docking, and finally exocytosis of the synaptic vesicle and leading to release of acetylcholine into the synaptic cleft. So there are different pools of acetylcholine. What are these pools? There are 3 types of pools: pool 1, pool 2, and the third stationary store. So pool 1 is 80% of the vesicles, which is released in response to nerve impulses. The second one is released under the conditions of low nerve activity, and this is 1% of the vesicles, and the remainder are the stationary stores. So release of acetylcholine in synaptic cleft. So when a nerve impulse invades the nerve terminal, calcium channels in the nerve terminal membrane are opened up. Now calcium enters the nerve terminal and there is a calcium dependent synchronous release of contents from 50 to 100 vesicles. The number of quanta released by each nerve impulse is very sensitive to extracellular ionized calcium concentrations. These increased concentration of calcium results in increased quanta. Now, vesicles must be docked at special sites. These are called as active zones in that part of the nerve terminal where the axon membrane faces the post-junctional acetylcholine receptors. So docking of the vesicles and the subsequent discharge of acetylcholine by exocytosis involves several other proteins. These are snares, soluble and ethylmatrimide sensitive attachment proteins are involved in fusion, docking and release of acetylcholine at the active zone. So this is a beautiful picture showing that first neurotransmitter has been taken up by the vesicle. Following it goes to translocation, then it goes to docking where it attaches to the presynaptic membrane. Then with the help of ATP, priming and fusion is done. Priming, fusion and docking is done. Then there is exocytosis where there is a release of acetylcholine into the synaptic cleft. Acetylcholine are shown in the orange and the red dots in the structure, in the yellow synaptic cleft. So now as we are talking about synaptic cleft throughout, synaptic cleft is a gap between the terminal bouton and the muscle fiber, which is about 50 to 100 nanometers wide. So muscle fiber is covered by the basement membrane or basal lamina consisting of collagen, glycoproteins and other extracellular matrix proteins. So synaptic cleft also contains acetylcholine esterase anchored to sarcolemma by ColQ protein. This acetylcholine esterase hydrolyzes the acetylcholine into choline and acetase as I told in the earlier slides. So what happens? Acetylcholine esterase ends the acetylcholine activity at the synaptic cleft. The muscle cell electrical response is turned out by the acetylcholine esterase enzyme which degrade acetylcholine to choline and acetate. Now 50% of the choline is transferred back to the presynaptic terminal by sodium choline transport. Now this is exocytosis shown in this very beautiful diagram. Exocytosis at the terminal boutons. So in the blue circle we are seeing resting nerve with abundant vesicles, followed by in the red we are seeing when the nerve is stimulated and there is vesicle exocytosis releases acetylcholine into the synaptic space. We can see in the red circle. Then in the green circle it is synaptic cleft, the potential space which is about 50 to 100 nanometers. The time for diffusion of acetylcholine from presynaptic to postsynaptic is 0.5 milliseconds. Now comes postsynaptic membrane. It contains acetylcholine receptors mainly. At the postsynaptic membrane, the area overlying the nerve terminal is called muscle end plate. The membrane here is thrown into primary and secondary clefts. The clefts greatly increase the membrane surface area. Shoulder of these clefts contain numerous acetylcholine receptors arranged in pairs.
So which protein connects actin to the Z line? Titin, nebulin, dystrophin, or tropomyosin? Okay, so Himanshu Mishra answered the quickest, and the answer is nebulin. So very good, Himanshu. You may continue, Sachin.
So now a photographic representation of motor end plate, where in the red we can see each vesicles and number, which are containing near about 5,000 molecules of acetylcholine, and one vesicle is equal to 1 quanta. Now each vesicle, as I told, it is 50 nanometers. Now postsynaptic membrane is shown by in the yellow, in the blue colored circle, where clusters of nicotinic receptors are present in the junctional folds. And then in the green we can see the synaptic space, synaptic cleft. Now the released acetylcholine diffuses to the muscle type nicotinic acetylcholine receptors which are concentrated at the tops of junctional folds. Now binding of acetylcholine to these receptors increases sodium and potassium conductance of membrane, and resultant influx of sodium produces a depolarizing potential. This is called as end plate potential. The current created by local potential depolarize the adjacent muscle membrane to firing level. Now acetylcholine is then removed at the synaptic cleft by acetylcholine esterase enzyme. Action potential is generated due to opening of voltage gated sodium channels on the either side of the end plate and are conducted away from the end plate in both directions along the muscle fiber. So the muscle action potential in turn initiates the muscle contraction. So this is the photographic presentation where we can see the main two receptors of the present on the postsynaptic membrane, that are the pink colored are the acetylcholine receptors. These are ligand gated, means whenever the acetylcholine molecules will only be attached to their attaching sites, it will open up. And the second receptors are sodium receptors, which are voltage gated and time gated receptors.
What is the effect of botulinum toxin at the neuromuscular junction? It enhances acetylcholine release, inhibits acetylcholinesterase, blocks acetylcholine release, destroy acetylcholine receptors. I think Kajal has answered it right. The answer is blocks acetylcholine release. So, very good, Kajal. You may proceed, Sachin.
So now, as I am talking about the receptors, so the muscle nicotinic acetylcholine receptor is a type of inotropic receptor. The receptor is made up of 5 subunits, 2 alpha and 3 non-alpha. The binding of two acetylcholine molecules opens the channel through a conformational change. In the photo, we can see that there are 2 alpha sites for the binding of the acetylcholine on the receptor, nicotinic acetylcholine receptor. The blue square-like structure is the acetylcholine. When it attaches, there is conformational change and the channels open up. When these channels open up, there is entry of the sodium that is marked in pink color, and at the same time there is exit of potassium. So with this, there is we can say that acetylcholine acetylcholine receptors are of 3 types: junctional or mature, located mostly almost entirely near the mouths of the subneural clefts. The extrajunctional or the immature ones tend to be concentrated around the end plate, and the neuronal alpha 7 ones that consist of 5 alpha 7 subunits, and each subunit containing 400 to 700 amino acids. Binding sites for acetylcholine are alpha 1 and alpha 7. Now comes to the second, that is sodium channel. It is cylindrical, containing membrane protein, has 2 gates. One, it is voltage dependent, voltage gate, which is marked in the diagram in the fluorescent green color, followed by time dependent, which is creamish marked in the diagram, time dependent. Now in this sodium channel, there should be both the gates, voltage dependent and the time dependent gates should be opened to allow the passage of ions. So voltage dependent gate is closed in resting state and opens only on application of a depolarizing voltage, remains open as long as the voltage persists. In the middle of all the 3 receptors, the middle one shows that there is passage of sodium ions when both the voltage gated and time dependent channels get open. Now,
so the last MCQ for this presentation is: select the correct chronological order of events in the presynaptic membrane during neuromuscular transmission. Opening of the voltage gated calcium channel, translocation, docking, fusion of synaptic vesicle to membrane, release of acetylcholine into synaptic cleft, influx of calcium into intracellular space, arrival of action potential at motor nerve ending. So who place it in the chronological order, whichever you feel is the right. So Abhijit has answered correctly, and the faster. The option is C. So it
okay, ma'am. So now moving towards the end plate potentials. So binding of acetylcholine with the acetylcholine receptors in the postsynaptic membrane of the motor end plate causes opening of ligand-gated sodium and potassium channels, which cause greater influx of sodium than efflux of potassium, leading to a more positive, that is localized depolarization of the motor end plate to about 50 to 70 millivolts, called as end plate potential. Now, end plate potential is not an action potential, but it is simply depolarization of the specialized motor end plate. So, miniature end plate potentials, small quanta or packets of acetylcholine are released randomly from nerve cells at rest spontaneously, each producing smallest possible change in the membrane potential of the motor end plate. This is the miniature end plate potential. Usually it is 0.5 millivolts. Now the significance is still yet not known, but probably responsible for the tone of muscle. So this at the end, it is the summary of the neuromuscular transmission through a videographic format. I'll be illustrating that. So this is the blue colored presynaptic terminal. Now it is having action potential, change in the action potential generation. Then due to this change, there is opening of voltage gated calcium channels and entry of calcium. Entry of calcium into the terminal presynaptic terminal causes docking and exocytosis of the acetylcholine containing vesicles. This is the release of acetylcholine shown in the purple balls. These attaches to the acetylcholine receptors and forms a complex due to which the receptors open up. And then there is a green ball, green ion showed in the video, that is sodium entry. Entry of this sodium again causes the depolarization of the muscle and motor muscle end plate. This depolarization causes a conformational change in the calcium channels present in on the sarcoplasmic reticulum. Now, in sarcoplasmic reticulum, there is 2000 folds of calcium collected. These calcium ions now open up and reach the troponin I part of the muscular contraction compartment, and by this the process excitation contraction coupling occurs, where actin and myosin filaments cross bridge each other, causing muscular contraction. So this is the purple balls are attaching to the troponin I component of actin myosin component, and after this there will be cross bridging and initiation of excitation and contraction coupling. So with this beautiful video, I here end my session. These are my references. And thank you. With this, I lay over my session to Dr. Pawan for continuing on the topic perioperative neuromuscular monitoring.
Okay,
I
Sachin,
think
thank,
yeah.
thank you for an excellent presentation. There are two questions which have come in from the audience. So would you like to take them on?
Yes, sir. Sure, sir.
So the first question, though you have covered it, but it came in a little bit early. So you would like to repeat the answer again for the benefit of the audience.
Yes,
So
sir.
the question is, what is meant by excitation contraction coupling?
So, sir, excitation contraction coupling is the muscular motor end part of the neuromuscular transmission, where after the depolarization occurs at the muscle motor end plate and calcium is released from the sarcoplasmic reticulum. These calcium ions bind to the troponin I part of the actin myosin component, and when these contract, these slide over each other to produce muscular contraction. So, this all process is called as excitation contraction coupling, sir.
So there is another question. Now this has got a very important clinical relevance.
Yes, sir.
So the question is, how does hypokalemia and hypermagnesemia
Yes,
affect
sir.
neuromuscular transmission? And the second part of the question is, what are the implications for perioperative care? So you first
Okay.
answer, how does hypokalemia and hypermagnesemia affect neuromuscular transmission?
So, sir, due to hypokalemia, there is increasing resting membrane potential, that is negativity or hyperpolarization. So, due to this, it becomes more harder for the threshold of the action potential to cause the neuromuscular junction excitability. Because of this, sir, we can have poor response to neuromuscular blockade as well as weakness at the same time. This happens because of hypokalemia. Now, coming towards the hypermagnesemia, sir. So it competes with the calcium channels, sir. Voltage gated calcium channels in the presynaptic membrane. So because of this, there is decreased amount of release of acetylcholine into the synaptic cleft. Now, due to this decreased amount of acetylcholine as released in the synaptic cleft, what happens that enhances the non-depolarizing blockade. Because non-depolarizing blockade, there is attachment of the molecules of the this non-depolarizers to the places where acetylcholine gets attached. So it potentiates the effects of the muscle relaxants. So and what are the perioperative, as you asked, sir, perioperative implications, sir? It is that because of this we can adjust the doses of the muscle relaxants, and monitor and quantitate the neuromuscular reversal as well as relaxation agents by the methods of TOF and other neuromuscular monitoring parameters. Thank you, sir.
Yeah, thank you. So the hypermagnesemia part is very important for all of us because often we are managing these preeclampsia patients who come for emergency LSAS, and most of the time we are not in a position to do the magnesium levels. So these patients, when we are using, if we are giving them GA, we should be very, very careful and keep this particular factor in mind during the management.
Yes, sir.
Thank you, Dr. Sachin. We'll now invite Dr. Pawan to present the second half of the presentation.
Thank you, sir. Good evening, respected faculty and my dear friends. So, continuing with my topic, perioperative neuromuscular monitoring. Why is neuromuscular monitoring? What is neuromuscular monitoring? Neuromuscular monitoring is a technique used to evaluate the effect of a neuromuscular blocking agent by assessing evoked muscle response to electric stimulus of its corresponding motor nerve. And the most common nerve muscle unit used for neuromuscular monitoring is ulnar nerve and adductor pollicis muscle. So in this picture, we can see a peripheral nerve stimulator, which is used for nerve stimulation. And why should we monitor neuromuscular blockade? As tests of muscular strength are highly unreliable indices of adequate neuromuscular recovery, and any residual neuromuscular blockade can impair carotid body chemosensitivity to hypoxia, leading to a decreased ventilatory response. So, residual neuromuscular blockade is associated with functional impairment of the pharyngeal and upper esophageal muscles, leading to regurgitation and aspiration of gastric content. So therefore, neuromuscular monitoring should be performed to exclude any residual neuromuscular blockade before extubating. And how do we assess muscle response? There are two ways. One is subjective neuromuscular monitoring and another is the objective neuromuscular monitoring. We say subjective when the muscle contraction is subjectively assessed by a clinician either visually or tactilely. And it is objective neuromuscular monitoring is like when muscle response is objectively measured with the help of a sensor and displayed on a screen. Coming to principles of peripheral nerve stimulation, Ohm's law states that voltage is equal to current into resistance. So muscle response is directly proportional to force of contraction, which is directly proportional to number of muscle fibers contracted, which is directly proportional to current. So the least amount of current required to begin muscle contractions is called as threshold current. And current required to produce contractions in all muscle fibers is called as maximal current. Coming to supramaximal stimulus is 2.5 to 3 times threshold current, that is 15 to 20% higher than maximal current. This ensures the stimulus to be truly maximal throughout the whole period of monitoring, irrespective of potential changes in skin resistance intraoperatively. And 30 milliamperes current is usually produces supramaximal stimuli in most of the patient when ulnar nerve is stimulated. But higher currents may be needed where posterior tibial nerve is used in patients with increased skin resistance, such as having diabetes or edema. Coming to the safety range of the equipment when we're using neuromuscular monitoring, neuromuscular block becomes evident only after 70 to 80% of acetylcholine receptors are occupied with non-depolarizing neuromuscular blocking agent. For a complete block to occur, 90 to 95% of acetylcholine receptors has to be occupied. But the currently available equipment detects up to 70 to 95% of range of receptor occupancy only. So during recovery of neuromuscular blockade, less than 70% of acetylcholine receptors occupancy is not detectable by neuromuscular monitoring. So here is a question,
Okay.
ma'am.
Yeah, okay. So the question is clinically evident neuromuscular blockade occurs when -% of acetylcholine receptors are occupied by neuromuscular blocking agent. Okay, so Dr. Muthu Kumar has correctly answered it. It's 70 to 80%. So very good, Dr. Muthu Kumar. You may proceed, Pavan.
The types of electrodes like silver, or silver chloride gel-based sulfate electrodes are used, and metal ball electrodes, where we can see the picture where only metal balls are there without any cables, and needle electrodes, and these are inserted into subcutaneous tissue parallel to the nerve. Choice of nerve muscle unit for neuromuscular monitoring. The commonly used nerve muscle pair for neuromuscular monitoring is ulnar nerve, in which adductor pollicis muscle, and for the posterior tibial nerve, flexor hallucis brevis muscle is used. And in the facial nerve for the zygomatic branch, orbicularis oculi muscle, and facial nerve for the temporal branch, corrugator superciliary muscle.
Okay, so which nerve muscle unit is considered as gold standard for neuromuscular monitoring? First option, posterior tibial nerve, flexor hallucis brevis muscle, ulnar nerve, adductor pollicis muscle, facial nerve, orbicularis oculi muscle, all of the above. Okay, so Dr. Abhijit has answered it correctly. It's ulnar nerve, adductor pollicis muscle. Good going, Abhijit. Yeah.
Continuing the topic, differential sensitivity to muscle groups to neuromuscular blocking agents. This variation is due to acetylcholine receptor density, acetylcholine release, acetylcholine esterase activity in the muscle, and muscle fiber composition of the particular muscle, and innervation ratio and number of neuromuscular junctions present, and blood flow to the muscle, and the muscle temperature. And coming to the pattern of nerve stimuli whenever neuromuscular monitoring is done, there is single twitch stimulation, and a double burst stimulation, and a train of force stimulation, and tetanic stimulation, and post-tetanic count. Coming to single twitch stimulation, and as we see the stimulation pattern, the frequency ranging from 0.1 hertz, where once in every 10 seconds it's given, and to 1 hertz, where once every second. And we can see a picture where the stimulation is equal in single twitch stimulation. And in the below picture, where we can see a response for the non-depolarizing block and depolarizing block. The non-depolarizing is shown in the color, where depolarizing is shown in the blue color. There is a progressive decrease in both responses height with both depolarizing and non-depolarizing muscle relaxant. And coming to clinical application of single twitch, it can be used to find supramaximal stimulus, can be used to identify whether satisfactory condition for intubation has been achieved. In conjunction with a tetanic stimulus, can be used to monitor deeper levels of neuromuscular blockade. And the disadvantages are control is always needed, cannot distinguish between depolarization and non-depolarization block, cannot be used to assess recovery, since return of response to control level does not guarantee full recovery. Coming to train of force stimulation. If we see the stimulation pattern, train of force stimulation consists of 4 supramaximal stimuli given every 0.5 seconds, which is of 2 hertz, and each stimulus in the train causes the muscle to contract. So in the picture, 4 stimulus of 0.5 seconds interval. And coming to train of force count. Train of force count is the number of evident response observed after train of force stimulation. So in the below picture, the 4 counts is the train of force count, like evident response. And coming to train of force ratio, the amplitude of fourth response divided by the amplitude of the first response. So in the picture where we can see the 4 amplitudes by T1 by T4, which gives us the TOF ratio. And coming to when the train of force used for the monitoring, and when non-depolarizing block or non-depolarizing muscle relaxant is used. So initially there's a control, and then there will be a progressive reduction in the height of the subsequent response observed with non-depolarizing muscle relaxant, and fate is attributed to the blockade of presynaptic alpha 3 and beta 2 acetylcholine receptors, leading to a decrease in acetylcholine release. So where we can see the fade has been there. And if we see the train of force in an depolarizing neuromuscular block has been done, in depolarizing block, there is an equal depression of all 4 responses. If fade is observed with succinyl choline, it indicates phase 2 block. Where in the below picture, where depolarizing neuromuscular blocking has been done in the phase 1 block, where we can see only equal depressions. And application of train of four. Train of four is the most sensitive indicator of residual neuromuscular blockade. It can distinguish between a depolarizing and non-depolarizing block. It can detect phase 2 block with succinylcholine. It provides an estimate of degree of non-depolarizing neuromuscular blockade. In absence of a non-depolarizing block, TOF ratio is 1. As a block deepens, TOF ratio decreases. MCQ.
Just taking it. Okay, so 20-year-old male planned for lipoma excision under GA was induced with injection propofol 2 mg per kg IV and injection succinylcholine 2 mg per kg IV and maintained on oxygen, nitrous oxide, isoflurane. However, at the end of surgery, there was no clinical recovery from muscle relaxation. Neuromuscular monitoring with TOF was started and following response seen. First, lack of recovery is due to high dose of succinylcholine. Patient is in phase 2 block and requires high dose of neostigmine for reversal. Patient is in phase 2 block and requires high dose of Sugama-dex for reversal. Patient is in phase 2 block and may require fresh frozen plasma for reversal. Okay, so
Ma'am, you have been muted, ma'am.
okay. So Dr. Raja Rajeshwari has answered it correctly. The option is D. Patient is in phase 2 block and may require fresh frozen plasma for reversal.
So continuation, the double burst stimulation. If we see the double burst stimulation, if we see the stimulation pattern, it is a 2 short bursts of 50 Hertz of tetanic stimulation separated by 750 milliseconds with a 0.2 millisecond duration of each square wave impulse in the burst. And DBS double burst stimulation has basically two modes, DBS 3:3 mode and 3:2 mode. In 3:3 mode has 3 impulses in each of 2 bursts, where DBS 3:2 mode has 3 impulses in the first burst and 2 impulses in the second burst. So in the picture below where we can see that is 3:3 mode of DBS. And coming to tactile detection with DBS, DBS 3:2 mode provides a better tactile detection of response compared to DBS 3:3 mode. And response evaluation, the response to DBS is evaluated based on the fading of muscle contraction, which is more profound in the second burst compared to the first burst. Clinical applications, it improved qualitative neuromuscular monitoring. For detection of fade, tactile evaluation of DBS response is more accurate than train of 4, but DBS is still insufficient to exclude residual paralysis corresponding to TOF ratio between 0.6 to 0.9. So qualitative neuromuscular monitoring with DBS cannot replace objective monitoring. Coming to tetanic and post-tetanic count stimulation, tetanic stimulation is a high-frequency electric stimulus of 50 to 100 Hz given for 5 seconds or 200 Hz stimulation for 1 second. And it should not be repeated more often than every 2 minutes. And coming to the post-tetanic count stimulation, it's a tetanic stimulation is after 3 seconds with 10 to 15 single stimulus at 1 Hz. Post-tetanic facilitation is the phenomena of exaggerated response to stimulation. The number of evident response to post-tetanic stimulation is called as post-tetanic count. It is due to exaggerated release of acetylcholine leading to high levels of acetylcholine with respect to receptors blocking drugs at motor end plate, where we can see post-tetanic count in the below picture. So if we see the pictures, there are 2 pictures. These are the response when it has been captured during a moderate anesthesia. In the first picture, it has been captured during the moderate anesthesia with a non-depolarizing muscle blockade in response to tetanic stimulation, where we can see decrease in amplitude associated with the fade plus post-tetanic fade. Where in the second picture, we can see it also has been captured during a moderate anesthesia, where depolarizing muscle blockade response to tetanic stimulus will decrease in amplitude but sustain and no post-tetanic fade will be seen. And coming to the objective monitors, which are used for neuromuscular monitoring, these monitors have a sensor which measures the evoked response objectively and they display it on the screen. So the different monitors are mechanomyography and accelerometry, kinesiomyography, electromyography, compressomyography, and phonomyography. Coming to see individually, mechanomyography. If you see my mechanomyography, it's a transducer which converts force of contraction generated at adductor pulses to electrical signals, which is recorded, amplified, and displayed on screen. Mechanomyography is a gold standard of neuromuscular monitoring, but not commercially available due to bulky equipment and used for research purpose only. Coming to accelerometry, it is based on the Newton's second law, where force is equal to mass into acceleration. It measures isotonic acceleration of stimulated muscle by using piezoelectric transducer. Most commonly available monitor and therefore becomes a standard for qualitative neuromuscular monitoring today. And coming to electromyography, this measures compound muscle action potential generated by stimulating of a peripheral nerve, and it contains of 3 electrodes, where the first electrode, the active electrode, will be placed over the muscle belly, and the reference electrode will be placed on the tendon insertion, and a ground electrode. Kinesiomyography. It's a bending sensor with a piezoelectric core is placed between thumb and forefinger. Muscle contractions cause bending of sensor, which is converted to electrical signal by piezoelectric transducer. Coming to the evaluation, when the neuromuscular monitoring has been done and the evaluation for the recorded evoked response is with the 4 levels. The first one is the intense neuromuscular block, and deep neuromuscular block, moderate neuromuscular block, and recovery phase. And coming to the intense or profound neuromuscular block, which is also known as period of zero response. It starts with the 3 to 6 minutes of injection of intubating dose of non-depolarizing muscle relaxant. There is no response to any pattern of nerve stimulation for both train of 4 count and PTC. And during this phase, acetylcholinesterase inhibitor like neostigmine cannot reverse an intense block. But a high dose of sugammadex, that is 16 mg per kg, can reverse an intense block caused by rocuronium and vecuronium. And coming to the deep neuromuscular block, it is characterized by no response of train of 4 stimulation and appears as a PTC post-tetanic count at least 1. And at least 6 to 10 PTC return of first TOF response is imminent. Deep neuromuscular block cannot be reversed by neostigmine, but sugammadex of 4 mg per kg can reverse deep neuromuscular block, which is caused by aminoesterase groups drugs like vecuronium or rocuronium. Coming to moderate neuromuscular block, it begins with the return of first train of 4 response, train of 4 response 1, followed by gradual return of next response to TOF between train of 4 count 1 to 3. If a train of 4 count 1, it shows that 90 to 95% acetylcholine receptors are blocked. If train of 4 count is 4 is seen, it says that 60 to 85% of acetylcholine receptors are being blocked. And a neostigmine dose of 0.05 mg per kg can reverse the block if train of 4 count is 2 or 3. Moderate neuromuscular block during light anesthesia, sugammadex dose of 2 mg per kg can reverse moderate neuromuscular block with vecuronium and rocuronium. Recovery from neuromuscular blockade. Return of 4th response in train of 4 marks the recovery phase. Train of 4 ratio is used to assess the extent of neuromuscular blockade recovery. And below we can see a tabular form showing TOF ratio with the clinical correlation. If it is less than or equal to 0.4, the clinical correlation is the patient will be unable to lift head or arms, and tidal volume may be normal, but inspiratory force and vital capacity is reduced. If it is between 0.5 to 0.6, most patients can lift head for 3 seconds, open eyes widely, protrude tongue, but vital capacity and inspiratory force is still reduced. If it is coming between 0.7 to 0.75, most patients can cough sufficiently, lift head for 5 seconds, but hand grip strength is still low. If it is coming around or equal to 0.8, vital capacity and inspiratory force become normal. However, patient may still have diplopia, blurred vision, and facial distress. If it is coming greater than or equal to 0.9 in mmg or EMG or 1 in AMG, then we can say that to exclude clinically significant residual neuromuscular block with certainty.
So the question is, which of the following statements about trainer 4 is false? Trainer 4 gives relevant info about the onset of surgical relaxation. TOF ratio can be taken as measure of neuromuscular recovery from neuromuscular blockade. Tactile visual estimation of fade is accurate when TOF ratio is more than 0.4. Intense and deep block cannot be differentiated with TOF ratio. So Muthukumar Rajgopalan has answered it correctly. The answer is tactile visual estimation of fade is accurate when TOF ratio is more than 0.4. Very well, Muthukumar.
Continuation. So we'll looking into the ASA guidelines for neuromuscular monitoring. The monitoring recommendation by ASA is quantitative monitoring is preferred over qualitative assessment to avoid residual neuromuscular blockade. And extubation criteria, confirm a train of 4 ratio at least 0.9 before extubation. And Sugomadex usage. Sugomadex is recommended over neostigmine for reversing rocuronium or vecuronium induced neuromuscular block at all depths. Alternative to Sugomadex, neostigmine can be used like reasonable alternative to Sugomadex at minimal depth of neuromuscular blockade. Antagonism recommendations for atracurium and cis-atracurium. Antagonism with neostigmine is suggested at minimal neuromuscular blockade. Coming to extubation timing, extubation should be delayed for at least 10 minutes after antagonism without quantitative monitoring. Or extubation can be done if TOF ratio is greater than or equal to 0.9 is confirmed with quantitative monitoring. Complications with neuromuscular monitoring, burns, which are more commonly observed with metal ball electrodes, nerve damage, accidental intraneural placement of needle electrodes can cause nerve damage and pain due to higher current strength stimulation in awake or partially anesthetized patient, and bleeding and infections can be occurring, and electrical interference, electrodes can interfere with ECG monitoring, and patients with nerve damage and neuromuscular disorders may not respond predictably to stimulations. And this is a summarization of the presentation, like whenever the reversal has been being used and where neuromuscular monitoring is being done objectively. And if the agent for the reversal is Sugomadex, then in the train of 4, if we see there is no response, and then later in the PTC is also coming to 0, then for the reversal, which corresponds with the deep block, intense block, where Sugomadex of 16 mg per kg can be used, and still TOF is there is no response in train of 4, and PTC is coming between 1 to 15, which corresponds to deep block, where Sugomadex of 4 mg per kg can be used for the reversal, and the train of 4 count is between 1 to 4. Then for the reversal with the Sugomadex, 2 mg per kg can be used, and if train of 4 ratio is less than 1, but train of 4 is less than 0.9, still then Sugomadex 2 mg per kg can be used. And if train of 4 ratio is coming equal to or greater than 0.9, then no reversal is needed during the extubation. If we prefer neostigmine as an reversal agent, and if we see train of 4 ratio when it is coming greater than 0.9, then no reversal is required. If train of 4 ratio is coming between 0.4 to 0.9, if reverse neostigmine is using as reversal, then neostigmine of 0.02 mg per kg need to be given. If a train of 4 ratio is less than 0.4 and train of 4 count is coming between 2 to 3, then neostigmine of 0.05 mg per kg can be used for the reversal. If train of 4 count is between 0 to 1, then reversal need to be delayed till the train of 4 count reaches 2 with neostigmine.
Okay, so the last question is, 27-year-old girl posted for inguinal herniorrhaphy under GA received 42 milligrams of rocuronium. However, 10 minutes later, the case was cancelled because of lack of surgical instruments. On NNM, her TOF count was 0 and PTC 1. How will you reverse this patient? First option, so gamma dex 4 mg per kg, neostigmine 0.05 mg per kg with glycopyrrolate, so gamma dex 16 mg per kg, or D, either it could be B or C. So Dr. Akshita has answered the quickest. The answer would be Sugama dex 16 mg per kg. So good going, Akshita.
So my references.
Thank you, Dr. Pawan, for an excellent presentation. The clinical aspects of neuromuscular monitoring. So there are two questions from the audience which I would like you to take on. So the first one is, in the absence of objective monitoring, how can tactile response to train of 4 and the double burst stimulation be used to assess the recovery?
So fade is difficult to detect by feel unless train of 4 ratio is less than 0.4. So 4 equal pitches does not guarantee a full recovery. So DBS is more sensitive with TOF to detect a residual neuromuscular block by touch.
Okay, and the second question is, what is altered TOF ratio and what is the advantage over the regular TOF ratio?
Sir, altered TOF ratio is also called as normalized TOF ratio or a baseline corrected TOF ratio. And it is a more accurate way of interpreting train of 4 ratio, especially whenever we are using acceleromyography. And the advantages is it prevents the premature extubation of a patient.
Yeah, that's correct. Absolutely correctly answered. So are there any, so we come to the end of the presentation now. Or are there any queries, public, any comments from the audience? Yeah.
Yeah, so Dr. Raj Rajeshwari has asked this question. Stimupod is also has single twitch, TOF, PTC, and double burst also. How does it differ from other monitors? That is the question.
Basically, StimPod was designed for use in the ICU. And the main function of the StimPod is the TOF monitoring in critically ill patients. It has all the other these parameters as well. It is versatile, it is mobile, and it can be very easily attached to the patient, very easily monitored. It can also be used in the OTs as well.
Okay. So, any other questions from audience? Thank you, Dr. Sachin and Dr. Pavan, for the excellent presentations, and thank you so much, faculties, for excellent guidance. And it was a wonderful presentation. If there are any further pearls of wisdom that are to be added.
So, any comments from our eminent teachers who are attending? I think Dr. Madhuri ma'am has a question or a comment.
Excellent presentations are on a very, very useful yet complicated topic. I just wanted to add that there was a fun question for Dr. Sachin and Dr. Pavan. Like the dose, would you would you decide your dose of neostigmine depending upon the response on the neuromuscular monitor?
Ma'am, if we are doing a reversal with
Question to आया नहीं ना?
Yeah, so we usually, the dose of neostigmine is how much? 0.05 milligram per kg, right? Yeah. So
But
now suppose you use the neuromuscular monitor and
ma'am,
the, yeah, and
yeah,
the post-tetanic count is less than 7. Would you give neostigmine?
ma'am, we will wait until 1 to 15 has been crossed.
Excellent. Because in this situation, it is going to be ineffective, right? Then which is the other situation where giving neostigmine will be ineffective? So this was a state of profound block, right? Where the PTC was less than 7, as I was telling you. Any other situation where you give, it's not worth giving neostigmine?
Ma'am,
I
if
think somebody asked a question also on this.
Is it? Yeah.
ma'am, if train of 4 count is also coming less than 0 to 1, then
Huh.
also wait till train
Huh.
of is 2 with neostigmine.
Yeah. And neostigmine has a ceiling effect also, right?
Yes, ma'am.
So what is the ceiling effect of neostigmine? Ki beyond a particular dose. What is that dose? If you keep on giving neostigmine, will it produce any changes in the response? It will not, because it has got that ceiling effect, as I told you. Yeah. And then there's one terminology called chronaxy and Riobase. Have you heard of it? This is in relation to neuromuscular monitoring. So sometimes some examiners do ask this. What is Riobase? It is the minimum intensity of electric current required to trigger an action potential in a neuron. Okay, so it is a minimum intensity of current which is required to trigger an action potential in a neuron. And it is a threshold for muscle excitation. You must have heard of these terminologies. I'm just repeating. And chronaxy is the minimum time and electric current of twice the intensity of the Rio base should be applied to elicit a response. So this comes in the physiology of neuromuscular monitoring. You may get sometimes, write 2 or 3 sentences on this, Rio base and chronaxy. Yeah. Any more questions from the audience? In a phase 2 block, what will be the picture on the neuromuscular monitor?
There will be a fade scene, ma'am.
Phase 2 block.
There will be a fade scene.
Aarti Kulkarni has raised her hand, our screen coordinator.
We will discuss the question after this question has been dealt with. There is one question from the audience. I will wait.
Yeah, so in the phase 2 block, no, we were discussing. Yeah, Dr. Pawan was telling us about the phase 2 block. So when does a phase 2 block occur?
When higher doses of succinylcholine has been given.
Yes.
Repeated and higher doses, ma'am.
Yes. Repeat doses or higher doses of scoline are given. So what will be the response on the neuromuscular monitor? Will it be the picture of a depolarizing block or a non-depolarizing block?
Ma'am, in top ratio, the fade will be present, ma'am.
Very good. Yes, there will be a fade on the top.
In double burst separation also, ma'am, there will be fade present, ma'am.
Excellent, excellent.
And ma'am, in post-tetanic count, ma'am, there will be present, but there will be of more depth. The fades will be of more depth.
Yes.
And
there will be potentiation.
Potentiation,
Yeah.
ma'am. And ma'am, with higher doses, there will be fades will be present, but there will be a time gap, ma'am.
Yes.
Time potentiated chronaxy, ma'am. There will be the chronaxy and Rio base will alter in this, ma'am.
Very good. Excellent. So phase 2 block nowadays, we don't get much cases, but we used to have, like, we used to give scoline and do cases on dilute scoline. So repeated doses of scoline, once they cross a particular range, particular dose. What is that dose? 6 milligram per kg.
Correct.
That time these kind of blocks used to occur, and we have faced these blocks also. So
Yeah,
nowadays, because you have got rocuronium and such short-acting muscle relaxants, we don't get to see these blocks.
and
I
another
think sir must have seen, no?
we have seen
Yes, sir.
During our time, especially the ENT cases.
Yes, sir.
Thought we used to talk
Mastoid.
about mastoid
Mastoid.
and removal of the foreign body from the airway or the esophagus,
Yeah.
repeated doses of scoline, and then
Yes.
patient never used to recover.
Yes, sir.
That
So the
was
surgeon says, I'll be out in 1 minute.
Yeah.
And we go on giving the scoline and
So
land
during
up
our
with the
time, I think that
patient.
was a very, very common situation,
Yes.
which we have seen phase 2 block.
Yes, sir. Yes.
And there is
Yeah.
another very rare reason which is given in Miller's and other textbooks, that is the genetically altered acetylcholinesterase. So that is the reason why you should never use neostigmine unless you are sure of the genetic pattern. In fact, neostigmine is not recommended at all. Never make the mistake of giving neostigmine in a phase 2 block.
Yeah. And nowadays, with the advent of Sugma-Dex, again, neuromuscular monitoring is important, because depending upon the degree of blockade, we
Correct.
can give the dose of Sugma-Dex, right?
Yes, ma'am.
Dr. Pavan and Sachin. Yeah.
Yes, ma'am.
Aarti, just carry on. Somebody else had a question there.
Yeah, Dr. Muthukumar has asked one question. How do temperature alter neuromuscular blockages and response to monitoring?
So, ma'am, with hypothermia, in hypothermia, ma'am, it is inverse relation. With hypothermia, there is prolonged neuromuscular blockade due to enzymatic activity. And ma'am, in hyperthermia, it is reduced neuromuscular blockade time. Yes, ma'am.
What happened? The answer was not complete.
Dr. Muthukumar, yeah.
Arey nahi, Sachin, you were giving answer?
Yes, sir, he was giving the answer.
He hasn't given the complete answer. Sachin, you are muted.
Sir, with hypothermia, there is prolonged neuromuscular blockade because of increased enzymatic activity. And sir, in hyperthermia, there is shorter duration of neuromuscular blockade.
Why there
Because
is
of
increased enzymatic activity in hypothermia?
Sir, because sir, it decreases the enzymatic activity of pseudochlorine.
Decreases. I thought you said increases.
नहीं sir,
No,
decreases.
hypomet decrease.
Hypo में enzymatic activity sir decrease हुई है sir.
Yeah, all gets deactivated. Enzymes, they get almost hibernated now in the pool of the plasma.
Yes.
So they are not active in the hypothermia. That's
Yes.
why you always, metabolism is lower in the hypothermia.
Hypothermia.
So whenever you see resuscitation are there, the hypothermia, we always prefer hypothermia in the resuscitation.
Yes, sir.
So apparent prolongation of action of neuromuscular blocking agents occurs because of lower metabolism.
Hypothermia.
Response. Yeah.
They take time to clearance also. Renal clearance also decreases. Hepatic metabolism also decreases.
So
regarding sir that neostigmine part, you
Yeah.
know what the golden rule is, what we have learned over the years, whenever you're going to give reversal, I think the previous notion of 3 to 5 minutes, what we have seen the PGs doing it in within 30 seconds. Nowadays, you just inject 1 ml of neostigmine. If you dilute it to 10 ml, if the 7 ml solution was coming, the 5 ml, whatever it is coming, dilute to 10 ml, give 1 ml, wait for some time.
Yes.
I think that gives an ample
Yes.
opportunity to
We used to
monitor
do that.
the
We were
neuromuscular monitoring also. as well as you will see the whatever the phase blockage also with that particular dosage of the neostigmine. I think that was a golden period where we have learned from over the years. But with the current teaching, we have seen the people injecting it in within 30 seconds to 1 minute, the neuromuscular blockade. There is one reversal agents. So that is, and even in ICU also, we never give the reversal agent. We just see let the neuromuscular blocking agent get phased out with the metabolism and the clearance from the renal tissues, rather than giving the reversal when we are weaning the patients off from the neuromuscular blockade.
Yeah, and with the atracurium coming in, people have become a little more casual, I think. There are a lot of people who do not want to reverse atracurium, which is,
Yeah.
again, the golden principle is that unless you have monitored TOF, you have to reverse.
I think Hoffman did a little bit injustice to the anesthesiologist by saying that degradation occurs very fast. It's not like that.
It's
There
not
are
like
many patients where the atracurium is more prolonged than even the vicronium. It depends on a particular enzymatic activity. And with the accumulation of the this one, all the metabolites of the atracurium, and especially the laudanocin, we not using it in ICU because that is going to cause more of the epileptic activities, especially in the neuro patients. We are not using atracurium at all. So these are few actually things that have to be taken care of. Arti, any more questions are there?
No, all done.
We are
No,
done.
as of now, that's all, sir.
Okay. So let us first now felicitate our faculty today. So Subir sir, thank you very much for the efforts. You prepared your team very well in an enthusiastic way rather. So many few teachers take the enthusiasm of conducting the class. So you were one of them. So thank you very much, Subir sir. This is a small gesture from ISA National
Thank
in
you, sir.
appreciation of your efforts to bring your team.
Thank you, sir.
And Neha, I think you must have done very hard work also with the PG students. I know they relate more to you because everybody is afraid of the HODs and professors. They don't go to them, they come to the next associate or assistant only. So thank you, Neha, for preparing them for this class.
Thank you so much, sir. It was an honor to be part of this. Thank you so much.
Sachin, yourself as well as अरे वो कहाँ गया पवन हाँ पवन and Sachin both thank you very much you at least I was thinking you made a blunder but I think you rectified immediately so these are the things you should be taking care of during examination also not to make any blunders like that blunders means sometimes when a mind thinks something and we speak something and the mind and the tongue they don't correlate so the different nerves and distal muscular structure in our body they don't correlate so that's why little bit error comes. So Pavan and Sachin, thank you. And Aarti, good composition, good anchoring.
Thank
And
you, sir. Thank
you are
you for
doing
the
good.
guidance.
Vigil, and so is Nimitha. Both are very vigilant screen coordinators. Thank you very much to both of you for
Sir.
holding this class.
Thank you, sir.
And what to say about Dr. Madhuri and Dr. Nishant, they are doing it well. So even if I'm not there for 10 minutes, they are holding it everything very perfectly. So these things are keep on going. So, where is Dr. Madhuri go? She always goes somewhere to drink water in between.
Sir, I'm here, sir.
I heard you went to drink water.
I'm here.
Okay. So, any more question from or any sir inputs from Dr. Subir sir?
No, I think there are no questions. So this is a very important topic. I mean, during our days, we never had any 2F monitors. We used to be very clinical. And today, everything has become so mechanical and dependent on 2F. But I think the clinical aspect of it, what you do and what you visualize, like giving, we were taught that giving the reversal over a period of 5 to 7 minutes, give it slow, wait, and gradually take out. So these are the things which have not been replaced by the machines. And that is what we need to teach our students, that never become dependent on the biophysical methods. Always trust your own clinical sense. That is very important, sir.
Even in present day times, whatever we have advanced, actually now I realize that whatever was being taught at that time, the clinical and logical explanations were limited at that time. Now, with the increased knowledge of, I think, our anesthesia resident, especially the incorporation of the concepts of the critical care and other part of the medicines, with so many of the specialties infiltrating into anesthesia, requiring the services of anesthesia, you have to read a lot of syllabus for that particular clearing the examination or getting a knowledge. So I think the PGs are more lucky; they are more enriched in the knowledge now they are acquiring. But I think even we are also learning to some extent with the present day advancements of the medicine subject. That what was taught actually, the logics were very clear now. They are becoming more transparent, more accomplished now. Things are getting better. And I always teach in the class that whatever the classes you are having on this PG online platform, they will be available on this one YouTube at ISNHQ, but you don't have to record the classes. You can download the classes from there also. But ultimately, the books will be your best friends. Whenever you are preparing for an examination, books, nobody can replace the books. These online courses and online classes are just for your supplementary to the whatever the books given, whatever been given in the books. So ideally, you should go to the books. And I think after this time, when you pass out, you do any whatever you want. You want to do the online, you want to do the mobile, you want to do any stage. But at least till PG, the books are your best friends. Don't leave the books. That is the teaching for the general teaching for the all the participants, all the PG students who are attending the online PG classes. Any more input from somebody? Dr. Madhuri, want to ask something again?
Yeah, I was just saying that though we have the neuromuscular monitor, there is no substitute to clinical judgment. So the neuromuscular monitoring has to be used as a supplement to clinical judgment and clinical tests throughout. So we should remember that.
I told in the beginning
And
also the same thing.
yeah,
Whatever
yeah.
the
So
clinical
repeat that. And one more thing is neuromuscular monitoring is not a part of the minimum mandatory monitoring of various societies. And I don't know whether it will in the future it will become a part of minimum mandatory monitoring, but right now it is not there in the mandatory.
Already the reason why, because see, the neuromuscular monitoring is required, especially where the surgeries require the neurological intervention, the neurosurgeries, the spine surgeries, or the prolonged surgeries, or somewhere you want to see the awareness on the waking up the people. Many short surgeries, the lap chole, the hernias, and why you want the neuromuscular monitoring there. So I think when the monitoring is required in every patient, then you bring it under the minimum mandatory guidelines. Otherwise, these monitoring guidelines are only for the special population. But I think even in that population, they may be the best guidelines. And nowadays, I think the gadgets are so much advanced with the monitoring standard. The digitally available gadgets are so good that they equally complement the good clinician. I think, but if the clinician is not good, suppose Sachin and Pavan, they just pass out. I think they may be having very good knowledge, but the learning curve of the practical issues are not there. So whenever they're going to take a help, I think the monitoring gadgets are best for them. By the time they learn also the over the time the clinical acumen over the years. So in the beginning, I think when we passed out, we always used to keep a hand on the pulse. No, now we have forgotten that art also because I don't think so. The pulse oximeters have become so intelligent. They monitor with the ETCO to monitor with SPO to monitor the beep volumes and rhythms, everything. We have forgotten that art, and don't think so. We are going to relearn or unlearn or new learn those arts. But I think people used to tell about even the blood pressure by holding a hand on the pulse because the baseline they always used to monitor with the pulse, and then even during the intra-operative period they used to tell that this must be the reading. But ideally, with the current way of the scientific advancements, it is not recommended to do like that when the medical legal implications are there, the clinical implications are there, when invasive monitoring is there. So I think that era is just, I think, passing by now. So we are more into the phase where we are accountable, answerable to almost everything. So whatever we are doing, so these are of a great help. The electronic gadgets are of great help. But as Dr. Madri told, you should not forget about your clinical profile and acumen. That is going to help you in the future also as a clinician. Suppose then just treat every patient as your own relative, as your own related to you, so that you will be able to monitor that patient much, much better rather than just a patient. That is a mantra for success in because anesthesia career is a very long career. You are the people who will be doing the anesthesia right from the first year of senior residency on to the practice. The surgeon may not be doing immediately after passing out. He may take another 5 to 10 years to get expertise. By the time the 10 years, you become so much clinically accomplished. That's the reason, a difference between the other specialties and anesthesia. You are clinically more, I think, polished people by another decade after passing out. So anything else, Nimitha and Aarti?
Thank you, Honorary Secretary ISA National Dr. Sukhminder Jeet
बार
sir,
बार मत बोलो सेक्रेटरी ऐसे बार बार अच्छा लगता नहीं है
respected faculty, senior moderators, and the students for such a wonderful and interactive discussion. The audience was definitely very, very active. Thank you very much.
Thank you, Dr. Aarti and Nimitha. I think it was a wonderful class. So, Dr. Subir sir, Dr. Neha, and Sachin and Pawan, thank you for being a part of this class, and wish you best for your examination coming in September. So, I think Dr. Subir and Dr. Neha will take a special care for you because you have done a wonderful job today. So, you have
Thank you so
already
much, sir.
cleared your pre-final actually. So, you will be appearing for the finals only now. So, thank you everyone.
Thank
And
you, sir.
good night. See you next Monday. And till then, we say goodbye, good night, and